Hi, welcome to leaRNursing's Endocrine System Review. This is part 2. In part 1, we looked at Cushing's, Addison's, acromegaly, SIADH, and diabetes insipidus. Now in this section, we're going to look at hypothyroidism, the thyroid gland, and the parathyroid gland. Let's get started. Now you should have in front of you the chart that lists out the hormones, what happens when you have too much, and what happens when you have not enough. So spend a couple minutes as we get back into the endocrine system and thinking through, do you remember, without looking at your notes, if I have too much ACTH, what am I at risk for? Perfect. Okay. If I don't have enough, I'm at risk for Addison's. Okay. Now, what's the worst thing that can happen to me in Addison's disease? You guys you're rocking. You got it. Okay. Now, growth hormone. If I have too much, what do I have? Acromegaly. It's probably caused by a tumor. Now, when I have that tumor, what do I have to have? Brain surgery. Through my face. You got it. Excellent. If I don't have enough, I have growth failure. Now, what about ADH? What does ADH stand for? Right. Anti-diuretic hormone. Heck no, we won't go. You're against diuresis, right? So if I have SIADH, I have syndrome of inappropriate anti-diuretic hormone, which means I have too much or too little. Too much. You had paused for just a minute. Okay, now the opposite of SIADH is diabetes insipidus. Okay, and as we walk through each one of these, they are the mirror image of each other. That's why when you spent time going through your stick man and comparing them, you can see that they have the exact opposite symptoms. Cushing's is a mirror image of Addison's, acromegaly, growth failure, SIADH, and DI. And once you know that, you've cut your studying time in half. Now, we wish we could do that on everything, but it works great in the endocrine system because that's what we're all about at leaRNursing, is changing the way that you study. Now, let's look at the thyroid. You've got your chart there. We're going to start looking at what happens in the thyroid and what it's used for. Now, where's your thyroid located? Right here, right? It's that little butterfly gland. And what does it have? 4 glands on top of it. What are those? Hey, aptly named the parathyroid. Excellent. So it's like a little bow tie or a little butterfly, and it's the one that controls the way our cells burn fuel from food to produce energy. So all of us wish we had a little faster metabolism. You probably know someone who seems like they can eat whatever they want and they never gain any weight. I don't like to talk to those people, but that's because their thyroid is really efficient, and they're probably eating the appropriate amount of calories and doing the appropriate amount of exercise. That's really how it works the best. But the greater amount of thyroid hormones that you have, the faster the chemical reactions occur in your body. So if I have a lot of it, you're going to see super fast reactions. If I don't have enough, it's going to be way slowed down. That's the difference between hyper and hypo. So the hormones that we're talking about, thyroxine is the metabolism one. Tridiphenol, can you even say those? They're very big words. They're both basically metabolism, are the first 2 on your screen. The last one is calcitonin, and it controls the calcium level in your body. And we'll talk about that a little bit more when we hit the parathyroid. If I have hyperthyroidism, that should make sense. And remember, the more thyroid I have running around, the faster those reactions are. So if you have hyperthyroidism, everything is fast. You talk fast, you act fast, you're hot, you move around, we're going to talk about that more. But hyperthyroidism is just, they're hummingbirds, they buzz. Hypothyroidism is the exact opposite. They're dragging. Remember when we talked about Cushing's? Cushing's disease, everything was really big and they had big blood pressure and big mood swings. Addison's was very slow. Same thing when you're talking about the thyroid hormone. That's what goes on. Hypothyroidism, and that makes perfect sense. Hyper, hypo. I think we're good to go to move on to the next one. Now, normal thyroid, the hypothalamus, picks up a stimulus and says something needs to change, whether it's temperature, your metabolism, something needs to be adjusted in your body. And it sends TRH to the anterior pituitary. Remember we talked about in part 1, the hypothalamus is just bossy. It's the coach, tells people what to do, so it sends a hormone that tells it to kick it out. So the TRH is sent to the anterior pituitary, which causes the anterior pituitary to send TSH to the thyroid. Now, what is TSH? Thyroid stimulating hormone. Remember, the stimulators come from there. TRH is thyroid releasing hormone. We talked about when we looked at the adrenal cortex, cortico-releasing hormone. So the releasing hormones are coming from your hypothalamus and they go to your anterior pituitary. And this one, when TRH is received by the anterior pituitary sends thyroid stimulating hormone to the Thyroid. There you go. So the target for thyroid stimulating hormone is thyroid. I wish everything that scientists names was this straightforward, but that's how it goes. So hypothalamus to TRH, TRH, the anterior pituitary sends out TSH, and it goes to the thyroid. When it hits my thyroid, what comes out? T3, T4, and calcitonin. Calcitonin probably messes around with my calcium. You're right. Okay, so you understand how the normal thyroid works. If you just walk back through these when you're looking at your notes, the best way to study is to take the notes as you go and then go back and review them. In fact, the best time to really lay things down in your brain is after you go to class and you've had lecture. It's that very same night, spend about 15 to 20, maybe even 30 minutes going back over those notes and saying, do I remember this concept? Where does it fit into the big picture? Why do I need to know it? And that will lock things into your brain if you'll review notes. So it's really hard because when you walk out of class, what do you want to do? See ya. You don't want to look at it again. You want to check it off. And if you've gotten into that really bad habit of studying as you go, like, for the, not studying as you go, doing the opposite of that. If you've gotten into the habit of studying for the exam the week, you go to class, you get your notes, you put them away, and you just study for the exam that's that week, and you don't look at that again until it's time for that exam. You want to make sure that you review things as you go. It'll be much more efficient for you. So now that I've talked to you about exams, see if you can remember from the hypothalamus to T3, T4, and calcitonin, and tell your neighbor, how do you get from the hypothalamus to T3, T4, calcitonin? Okay, so it should have been what? TRH to the anterior pituitary. Anterior pituitary sends out TSH. TSH goes to the thyroid, and the thyroid sends out the T3, the T4, and the calcitonin. Okay, so now we're going to talk about hypothyroidism. So that's where most of us are in your semester. It's caused by something going wrong with the thyroid. Either you have an atrophy of the thyroid, which means, we talked about atrophy of the adrenal cortex. It's not working like it's intended to. Or you have something called Hashimoto's. That should stick in your brain because it's kind of catchy, kind of fun to say. We have a character called Mr. Know-It-All. He's a 9-year-old, and he loves to say Hashimoto's. And you can imagine it always comes with hand signals because little boys love everything that's fighting and things. But when you think about hypothyroidism, I want you to link it with Hashimoto's, because Hashimoto's disease is another autoimmune disease that goes after your thyroid. We've talked about autoimmune diseases that go after your adrenal cortex, and go after your other organs, and it can go after your thyroid. You can also be at risk for this post-op, postpartum, lithium, or on amiodarone. Now, if it's not bad enough, all the changes that go through a woman's body when she has a baby, she's also at risk for hypothyroidism. So now that she has the baby weight, it's going to be even harder for her to get the baby weight off. And we wonder why depression can become such an issue after that. So we've looked at what are the causes of hypothyroidism. We talked about the thyroid atrophying. What was the name of the autoimmune disease? Okay, so what was the name of the disease? Yeah, it's more fun to say than that than you guys are making it. And I can be at risk to go into this post-op, postpartum, lithium, and amiodarone. The last one is, for some reason, the anterior pituitary just doesn't make enough TSH. For whatever reason, it's just not doing what it's supposed to do. So how do we treat it? We replace with just the medication, the levothyroxine. So you know how it happens, you know what causes it, you know how we treat it. We need to replace that hormone. Let's look at what it looks like all the way through your body. So if you don't have enough, chemical processes are going pretty slowly in your body. So your thinking slows. You become very forgetful. The worst thing that can happen to you in Addison's disease was an Addisonian crisis. The worst thing that happens to you in hypothyroidism is a myxedema coma. You are come to a crunching halt. Life stops. This is another example when anything in the endocrine system, if you don't fix the underlying hormone imbalance, you're not going to fix the other symptoms. So, hypothyroidism, myxedema coma. You're done. Okay, so these people can't respond to stress. You don't want them cold, and you don't want them to get stressed out. Now, what are the things that would qualify as stress for somebody? If I had Hashimoto's disease, and you know that I have hypothyroidism, And what are the things that you would want to help me manage in my life? What would qualify as stress that could throw me into a what? What's the worst thing that can happen to me with Hashimoto's disease? Coma. That's right. So you say it that way, you'll never forget. What are some things that could throw me into a situation where I'd be at risk to be in that coma? Nursing school. That's right. Survey says, ding, 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 number one answer. That's right. Nursing school. Anything else, whether it's physical, psychosocial, whatever's going on, that qualifies as stress. You know that what's happened in your life. It absolutely happens to somebody because you can't respond. Their body can't kick in and respond the way it's supposed to. So hypothyroidism, things slow down. My thinking, I get forgetful, all things going on, myxedema, coma. You've got to replace that hormone for me. So we've talked about neuro. Now let's look at cardiovascular. What would you expect? We kind of lump the vital signs in with this one, but if you're thinking about everything's slow, I'm going to have a low heart rate, and I'm going to have a low temp. These guys are cold. Not mean cold. Their temperature is cold because things run slowly. They tend to be very, very cold. They can't also respond. So if you put them in a room that's cold or the weather is cold outside, they have to make sure that they take precautions because that will stress out their body and they can't respond. So it's not just a matter of you being a weenie or being, cold-natured. It actually has physical implications for them. Somebody with hypothyroidism that has to deal with the cold. Skiing might not be their best sport to pick up and try. Now let's look at their lungs, the pulmonary, the respiratory system. What would you expect? If we have a low temp, a low heart rate, you would expect a lower respiratory rate. Literally, everything slows down. We don't call it myxedema coma for anything. So, or for nothing, whichever way you want to go. Now, what would you expect to happen in GI? Well, if we know that if you have a lot of thyroid in the body, your chemical process is faster. If I don't have it, weight gain. Remember, we talked about that's really a challenge after having surgery or after having a baby. Nobody wants to put on extra weight. So you can end up with weight gain. Increased cholesterol. It's kind of an odd one, isn't it? But the bad things go up, unfortunately. And they can end up constipated. Who else have we talked about, beginning in part 1, that you remember? Who was issues with constipation? Somebody who was dried out. Who was dried out? Yeah. As you're studying, keep asking yourselves those questions. Anyone who is dried out has an issue with constipation. Anyone who's slowed down like this has an issue with constipation. So the more you can link things in your brain, and remember, yes, these two disease processes have this in common, and here's why. This one has extra fluid because they have extra salt. This one is low because they don't have salt. All those things you can link up will help it lock it in your brain because it's all about recall, is it not? You all have a lot of stuff in your brain. It's just getting it out on a test question. Yeah, because we've all walked out of a test going, excuse me, do I have the right book? Because I'm very certain that wasn't the test that I'd studied for. Okay, let's look at the urinary tract. And they have a decreased interest in sex. They're not interested in life, let alone in sex. That takes a lot of energy, and they don't have it to give. But they can also have frequent heavy periods. So you need those things with wings and strength if you're dealing with hypothyroidism. When you think about musculoskeletal, they have numbness and tingling and dry skin. So is there anything about hypothyroidism you'd like to pick up? No, it's not a pleasant experience from head to toe. It's not really something that you think you probably want to try. So like any other endocrine disorder, what are you going to have to do in order to fix it, in order to help them get better? Replace it. So that's what you do. You replace the levothyroxine, and you treat the symptoms. And you see that's a common theme in every one of the endocrine disorders that we're talking about. You have to replace the hormone, and then you treat the symptoms. And we have the pleasure of doing them at the same time because we're not taking a nursing exam right now, having to split the hair and decide which would be the first thing, the most important thing that we would do before you went home. Okay, let's look back at your chart again. We're looking at the chart that says endocrine disorders. We know what happens with ACTH, GH, ADH. Now we're looking at thyroid. So when I don't have enough thyroid, it's called hypothyroidism. Thank you. That's easy to remember. But some of the things that can happen to me, you want to link to that in case you see a question, is Hashimoto's, which is an autoimmune disease. And the worst thing that can happen to me with hypothyroidism is a myxedema coma, where everything is slowed down. My thought process, my heart rate, my breathing rate, my GI, my gut, my desire for anything of a personal nature is slowed way down. Okay, so let's look on. Again, remember what normal thyroid is. Can you remember without looking at your notes? It went from hypothalamus. What came from the hypothalamus? We're going to get kicked out with thyroid. Sweet! TRH. Good job. Now, TRH goes to the... Yeah, it's always a safe answer to say anterior pituitary, because, like, how many things go to posterior pituitary? Not very many. So, hypothalamus, TRH goes to my anterior pituitary. You hit my anterior pituitary, and what do I kick out? TSH, otherwise known as thyroid stimulating hormone. So it goes to my thyroid, and I kick out T3, T4, and calcitonin, which we're pretty sure messes around with your calcium level. We'll talk about that more. So hyperthyroidism is our mirror image, right? Hypo, everything was slow. When you hit hyper, we got a whole nother ball game. You can get a whole lot more accomplished. Hypo people never can hit their goals because it takes so much energy for them to do it. Hyper are hitting theirs and everything the hypo person wanted to do. It can be caused by a toxic goiter or a tumor in their pituitary gland. The pituitary gland ends up with some weird things because it ends up sending them extra hormones. So that's why you end up with an issue if you have a tumor in your pituitary gland. Now, we call hyperthyroidism Graves' disease, because you will work yourself into the grave. I'm not sure why. It's actually probably the person who discovered it. But hyperthyroidism is Graves' disease. Hypothyroidism was Hashimoto's disease. You want to make sure that you link those, because you're likely to find a test question that will say Hashimoto's instead of hypothyroidism. You want to make sure that you're clear and you remember that. So 3 causes of hyperthyroidism: goiter, tumor, and we just call it Graves' disease. That's what it started in. So let's go head to toe like we've done with our stick man. We're going to look at the neural system first. These guys are, they're wired up. Do you usually know somebody who's like that? Are they ever calm? No. These are not people you want to carpool with or be in a group project with. You'll want to kill them if you're locked up with them for very long. They're agitated. They can't sit still. They can't move. They just have to be moving. It's not their fault. They're chemically wired that way, but that's how they feel if they're out of control. And they have those bug eyes. You know what I'm talking about? We call it exophthalmos, but you know what I'm talking about. It looks like their eyes are going to pop right out of their head. And they're going to have goiters. So when you're thinking about the hyper, everything is fast and big. Their mood, their attitude, their eyes, and their goiters. Let's look at cardiovascular. So we've done neuro. Now we're looking at cardiovascular. Everything in Hashimoto's was slow. Everything in this is going to be through the roof. So you have elevated heart rate, elevated blood pressure, and you can end up with some dysrhythmias. You're really stressing your body out in Graves' disease. My niece had this, and it was really tough for her because all kinds of weird things were happening to her body. Didn't know what it was. We'll talk a little bit more how that felt for her, but her heart would just race, literally just like a hummingbird, and they didn't know why for a while. It took them all to figure it out. Respiratory. Of course, if it was slow in Hashimoto's, it's going to be fast in Graves'. It's going to have a higher respiratory rate. See, these get a lot easier, don't they, as you go through them? You see the patterns? These guys are going to lose weight because they are burning it off. The chemical processes are happening faster. They're moving faster. All kinds of things are going on. So they're going to lose weight, and they're going to have an incredible appetite. These people are not going to be well liked by their friends because they eat and eat and eat, and they're losing weight, and they're constantly moving, constantly going on. So it doesn't make you very socially popular. Now, what would you expect skin and mobility? If they are revved up, are these going to be the people that are wearing sweaters in a conference? No. These are the people in winter that got spaghetti straps and shorts going on. Everybody else is in parkas and muffs and everything else. My niece could not stand to wear anything less than shorts because she was so hot. They're sweaty all the time. So they're real shaky, and they are hot, hot, hot. If you know somebody who's having palpitations, they feel warm all the time, those are classic signs that they're dealing with, possibly dealing with hyperthyroidism. So how can we treat it? Well, there's some radical ways. You can do a subtotal thyroidectomy, which they really don't like to do as much anymore. We used to do it a lot, but we don't. After a subtotal thyroidectomy, here's a classic nursing school question. You have to watch your patient for calcium. Now, why would that be? My thyroid is right here. You have that calcitonin. What's also on my thyroid? my parathyroid. We can call that surgical misadventure, which means they meant to take out the thyroid, but we clipped a little bit of the parathyroid too while we were in there, no extra charge. And we probably won't tell you we did it either. But if you have a subtotal thyroidectomy, you want to make sure you watch them closely for their calcium monitoring levels to be thrown off, because we might have done some damage to that parathyroid. We give them a drug called PTU, and I really would make sure that you star that in your notes. This seems to be something that is another classically tested concept. The PTU, which I can't pronounce that, maybe you can at home, but it inhibits the synthesis of thyroid. So if you're someone who is hyperthyroid, you got too much thyroid going around, we give you this drug, you can know it as PTU, and it will stop the synthesis of thyroid, because that's what we're trying to bring down. Now, oftentimes, instead of the subtotal thyroidectomy, the surgery, we'll go with something like radioactive iodine. The patient eats no salt for several days, so they have low iodine, and then they swallow a pill that's radioactive iodine, and the thyroid will suck it up. It's pretty cool, really pretty low risk, and it's a lot better than putting somebody through surgery. And that radioactive iodine will block the T3, T4, it decreases the vascularity of the thyroid, and the thyroid pretty much bows out, checks out. So that's a fabulous way to do it, and a lot lower risk. You can try that. They usually don't do the surgery unless they absolutely have to. It just doesn't respond. Now, the last piece is propranolol. Now, you know, whenever you see a drug that says OLOL at the end, OL, that's a beta blocker. When we say beta blocker, that means beta, meaning sympathetic nervous system. So beta adrenergic, beta blocker. You see those terms interchange used. But the sympathetic nervous system is my fight or flight, right? That means I'm about to be mowed over by a semi if I don't get out of the road. I'm ready to run. So when you hit my sympathetic nervous system, what happens? Everything races. My heart rate picks up, I bronchodilate because I'm gonna get ready to go. What happens to my gut? Slows down. Now, why does it slow down? If you think everything speeds up, how do you remember that? Well, those of you that have come before, you know why in the sympathetic nervous system. That's my fight or flight. I'm getting ready to run. I don't want to drop anything personal, do I? So I don't want to drop anything here, and I don't want to drop anything here. So what would I drop here? That would be my GI tract. I don't want to leave anything. What would I drop here? A baby. So what happens to my uterus? It relaxes. It does, what does it do? Thank you. It tightens up. What do I know? Here, you teach. Just kidding. All right. Because I don't want to drop anything here or here. So that's what we give women, a beta adrenergic agonist, so that we can stop labor. We want to hang on to that baby, not let it go. But my heart rate goes up and my bronchs dilate. So in Graves' disease, you have kicked my sympathetic nervous system into overdrive. That's why the body is so revved up. So what you want to do is give me a beta blocker. What does that mean? The drug gets to those receptors instead of all the neurotransmitters. So you block that response. That's what beta blocker means, right? So if you give me a beta blocker like propranolol, that's going to help me with somebody who has Graves' disease or is hyperthyroid, because you're going to block that sympathetic nervous system response. So when you think about how am I going to treat somebody with Graves' disease, without looking at your notes, think about the things. What can we do? I can do surgery. I can go after it. But then I have to watch you for calcium, because you might have taken out my parathyroids. I can take a pill. What's it called? Radioactive iodine. That might knock it out, but make sure I don't have salt before you take it. What other medicine can I take? It's got 3 letters. PTU. I can take that because that'll knock it out too. Okay, now, and the last piece was a medication that other people take, beta blocker, and you understand why. So if you're thinking about how would I treat Graves' disease, those are all your options. Surgery, PTU, beta blockers, radioactive iodine. You got it down. Okay, let's move on. If I go into a thyroid storm, that's an example of the worst thing that can happen to me if I have Graves' disease. In Addison's disease, it was an Addisonian crisis. What was the other endocrine disorder that the worst thing that can happen had a name? What was it? You can even look at your notes if you can't. Got it? Okay. What was the question? Now I do feel like I'm at home. All right. If I have hypothyroidism, what's the worst thing that can happen to me? You got it. I didn't word the question very well. Myxedema, coma. You always want to focus on what's the biggest risk for my patient, what puts my patient most at risk, Will I recognize it? What should I do about it? And that's, in a nutshell, what you're looking for in nursing school exams. So a thyroid storm is the worst thing that can happen in Graves' disease. You end up with a fever greater than 104. What happens to my cerebellum at a fever of over 104? Yes, you're poaching my brain at that. So you don't want to hang out at a fever of 104. It's also extremely hard on my body. So I can end up with all kinds of neural gigs like seizure, coma, definitely agitation. I'd be a little more worried about the seizures and the coma. CHF, increased heart rate, increased blood pressure, because you're just throwing that body under so much stress, you can literally throw them into congestive heart failure because of all the extra stress. So in Graves' disease, the thing I want to avoid is thyroid storm. Sounds like a nursing school test question, doesn't it? They give you those. Now, they don't tell you it's a thyroid storm. What will they tell you? Your patient in room 3104 has, if you've taken his temperature, the aide reports to you that his temperature is, you know, they get those big, old, long, wordy questions. Anyone have those at their school? And the people said amen. Yes, that's what they're looking for. So let's go back to your chart, the endocrine disorders chart. And you've got one more slot to fill in. Now you know what to put in where you have too much thyroid. What should you write in there? Hyperthyroidism, great, and Graves' disease. Okay, and the worst thing that can happen is just what you said, thyroid storm. So make sure you get that added in there too. Okay, so we've walked through thyroid, and you know the difference between hyperthyroid and hypothyroid. You know the drill. Here you go. Stickman's back again. On one side, write your symptoms for Graves' disease down, and on the other side, Hashimoto's. Okay, so you're working on Graves' disease and Hashimoto's disease. If you've already zipped through yours, compare notes with your neighbor and see if you missed anything. Okay, how'd you do? Now, when you go home tonight, try and redo all these stickmen without looking at your notes. See if you can compare and do the mirror images. The cool thing about this is, if you remember it for one, it will jog your memory to remember it for the other one. So that's cool. All right, let's look at the parathyroid. This is one of the last ones we're going to look at. Parathyroids that we've talked about are attached to the thyroid gland. They're 4 little tiny glands if you're normal. Some people have extra ones. Isn't that odd? I don't know how you find out. I'm not really interested. I don't want to know that much, but yeah, some people even have more than 4. But they release the parathyroid hormones. We just call those PTH, the little polypeptide gigs, and they control calcium in the body. Now, we've been talking about calcium. Now we're going to really get down to it and how it works. Because the PTH is what increases calcium in the blood. It enhances the release of calcium from the bones. So the way we get calcium in our blood is the parathyroids control it, parathyroid hormone, and what they do is they pretty much tell the bones to give it up. So you can kind of start to think what's going to happen if you have too much going on. There's going to be some issues with our bones. So it tells the bones to give up the calcium. It also tells the kidneys to reabsorb more calcium, and it enhances the absorption of calcium by increasing the production of vitamin D. So we just talked about 3 ways that PTH increases the calcium in your body. The first one, without looking, was what? Get it from your bones. The second was tell your kidneys to hang on to it. And the last one was vitamin D. Okay, so you got that solid? So you have increased calcium 3 ways: from your bones, tell your kidneys to hang on to it, or vitamin D. Those should start help you ring a bell too. And you start thinking about, oh, this is what happens when I have a vitamin D deficiency. That's going to give me issues. If I have too much of it, it's going to go after my bones. If I don't have enough of it, well, let's get on with it and help you lay it out. So increased calcium, the parathyroid hormone, is the one that takes it from, its job is to increase the concentration of calcium in the blood. We just talked about that. Calcitonin, now where'd that one come from? The thyroid. If PTH is what raises the calcium level in my blood, calcitonin is the one that decreases it. So if you want to link those in your brain, those guys are mirror images of what they do. They decrease the calcium, and it's produced by the thyroid gland. PTH also decreases the concentration of phosphate because it tells the kidneys to hang on to more, to reduce how much it hangs on to. So PTH increases calcium, but it decreases phosphate. And phosphate helps with bone demineralization. That's a nice way of saying ripping out what those bones have to give up. So if I have extra calcium in the blood, this is when we start hitting that feedback. When the parathyroids pick up that I have extra calcium in my blood, what do they stop doing? Putting out PTH. And that's another example of negative feedback. We've talked about that a couple times before we hit here. Where does calcitonin come from? Thyroid. Okay, so if the thyroid's doing its job, it can help put that out and help us deal with the calcium level too. The calcium sensing cells are where? Where are they located? Did I hear you say parathyroid? Excellent. There you go. I saw a lot of eyebrows going very high into their foreheads. Yes. So the calcium can seem like it gets a little tricky, but just hang on because it's parathyroid hormone, and we get it from 3 places. See if you can tell your neighbor those 3 places again. Okay, so the parathyroid hormone increases calcium. It decreases phosphate. So we've got another one of those inverse relationships, right? And when the parathyroid glands pick up that we got enough calcium in their body, the feedback tells us to inhibit that, to slow it down. Now, if I don't have enough, if I am hypoparathyroid, I don't have enough PTH. So lack of PTH is hypoparathyroidism. What causes it? We already talked about this a little bit in the previous section. What are some examples that could cause me to not have enough PTH? Thyroid surgery, yes, and we gave that lovely name, surgical misadventure. It really spells out too, lawsuit and liability, probably, but that's a whole other topic. So we inadvertently removed your parathyroid during your thyroid surgery. Now, you can also have, shock of all shocks, an autoimmune disorder. Some type of autoimmune disorder can take out your parathyroid glands, or you could just be born with it, and it's just the way it was. You just came wired that way. They had those issues. So I know my parathyroid is here. I know that it controls calcium. I know it can crank it up or back it off. I know that it gets this calcium from my bones, tells my kidneys to hang on to it, or what was the third one? Vitamin D. Now, how can I end up with not enough PTH? Hypoparathyroidism, surgical misadventure, sounds like something Dora wouldn't go on, an autoimmune disorder, or I just was born this way and that's how it works. So let's look at what it looks like in my body head to toe. I don't do well with this. I'm anxious, I'm confused, I have some psychoses and seizures. I also have difficulty swallowing. So you don't want to mess around with my calcium because it's really important to my cells. Yeah, mess around with my calcium and I get really upset and I have a hard time swallowing. Look at the cardiovascular system and what happens there. End up with decreased cardiac output, hypotension, and dysrhythmias. Calcium is very important on a cellular level in keeping all the electrical things running well. So not enough calcium, I'm not pumping as efficiently, I got the decreased cardiac output, low blood pressure, and I can get into some funky rhythms with this depending on how low it goes. Now, it can also cause laryngospasms. In the respiratory system, you want to add this laryngospasms. Again, this is another one of those things. I'd like just a wee bit of Graves' disease for 100, please, but not anything to do with these other gigs going on. It's really important your calcium levels stay normal. So laryngospasms go along with hypoparathyroidism. This one is going to be a little tricky for you to remember because these seem very oddball without going into a lot of, but if you just remember, calcium, extremely important on a cellular level. Important to my heart, important to my lungs, important to my cells, and it really just wreaks havoc. Because these look like some oddball symptoms that you'd see on a nursing exam, don't they? Yeah. We get paid extra if it's a really tricky question like that. We get a bonus. Now look at your GI tract. Things don't go well here either. Cramping, diarrhea, and on your diet, you really want to educate your patient to increase their calcium and decrease their phosphorus. Because in hypoparathyroidism, they have decreased calcium, and when I have decreased calcium, I have increased phosphorus. So it would be helpful to them if they would really try and manage it in their diet. Can you imagine trying to eat a diet with increased calcium and knowing which foods have phosphorus and how complicated that is for patients to follow? That's when you need to call a consult and have a dietitian involved in the care because they can really help them out with that. So because of the low calcium, it would really be a good idea for you to look through, as you're preparing for nursing exams, what happens with high potassium, what happens with low potassium, what happens with high magnesium, what happens with low magnesium. With low calcium, you have muscle spasms and tetany. You have those hyperreactive deep tendon reflexes, numbing and tingles in my tongue, numbness and tingling in your fingers and toes, and you have those two classic signs, Chvostek's and Trousseau's. Remember? Chvostek's and Trousseau's with the blood pressure cuff. So make sure you know those because those tend to show up on exams too. So you got Chvostek's and Trousseau's. And that tells me that I have high calcium or low calcium? Low calcium. Low calcium equals tetany and deep tendon, hyperreactive deep tendon reflexes and the numbness and the tingling and Chvostek's and Trousseau's. So whatever you have to do to lock those in your brain, that goes right up there with how do you know if it's CSF fluid, you want to make sure you know Chvostek's, Trousseau's, low calcium. Who's most likely to have low calcium? Anyone who got a bad draw for a surgeon. There we go. Had it taken out with their thyroid. Someone who had an autoimmune disease, or what was the last one? They were just born that way. Okay, so how do we treat it? Well, let's see. It's an endocrine disorder, and we usually replace things, and things get better. So we give them calcium gluconate, and we replace vitamin D. Makes sense, because that's why they end up in that way anyway. So that's the treatment for it. All right, you are filling in. We've only got one blank left after you fill this one in. So under parathyroid hormone, if you don't have enough, we're looking at your chart again. If you don't have enough, you have hypoparathyroidism. And the keys you want to link to this, Trousseau's and Chvostek's, you got it. Okay, now, before we go on, what I want you to do is cover up the column that says too much, not enough, and see if you can walk through what we've already done. Okay, now are you impressed with yourself? Pretty amazing, yeah. And if you keep reviewing it, you will own it. It will be yours, I promise. So, anybody want to guess what we're going to talk about next? That's right. There's only one blank left, so we're up to, yes, hyperparathyroidism. So this means I got too much PTCH because one of the quads is hyperactive. One or more of the quads are hyperactive, and those glands are putting out more than they need. What can do it to me? Same song, isn't it? Tumors or renal disease. Even renal disease can kick this in. So if I'm thinking about somebody who has renal disease, I have to watch them for elevated calcium, and this is why. Renal disease can kick that PTH into a higher level and end up with elevated calcium. And if I have a decrease in vitamin D, man, kidneys, we're going to do a renal section next week. It's amazing to me all that they're involved in. They do a lot more than filter, don't they? Blood pressure and hormones and all that they're involved in. So hyperparathyroidism, these three causes, tumors, renal disease, and decreased vitamin D. Now, if you think you're a hot shot, think back, what other endocrine disorders have we talked about today that are messed up by tumors or caused by tumors? See if you can think of one. Good deal. Yeah, it's pretty common, isn't it? Now, one tumor causes me to have a special kind of brain surgery. What is it? Transphenoidal hypophyseectomy, what do we call that? Brain surgery through your face. All right, good job. So let's look at what it looks like again, head to toe hyperparathyroidism. They have personality changes. Isn't that something? And they have altered mental status, decreased level of consciousness, and they are very thirsty. This one I think is the weirdest one that we talk about today. So they don't act like themselves. They have their mental status that you don't want them out in public, and decreased level of consciousness, and they're very thirsty. They're hypertensive and have weird dysrhythmias. Now, with hypoparathyroidism, did they have dysrhythmias? Okay, so there are some things you can start to link together. Okay, at least those were similar. Those are the same kind of thing. Look at the GI system. It doesn't go well for hyperparathyroidism either, does it? You've got pain, constipation, and nausea and vomiting. Here's something that's unusual, though. You end up with hyperparathyroidism, end up with extra calcium. That can give me issues with kidney stones. Anyone ever had a kidney stone? They're amazing. ER nurses can spot them a mile away, can't they? Because I have honestly talked to women who have birthed a child and birthed a kidney stone, and they would take the kid again, labor, any day. It is excruciating pain. I hate to tell men that because they get all fired up about that. But yeah, it's incredibly painful. So renal calculi or kidney stones, they have an increased absorption of the calcium, which is what causes the increased serum calcium, and they have an increased excretion of the phosphate. Anytime I have extra calcium, I'm going to have less phosphate, right? If I have high phosphate, I have low calcium. Got that down. And they have polyuria. Now think back. These guys are peeing out a lot. What do we say about thirst for hyperparathyroidism? Did it say they have thirsty? Yeah, and it's because they're putting out a lot. It's amazing they can still have the hypertension and dysrhythmias, but that's what happens. Now, the next slide should know we're going to talk about skin and mobility, but we're going to go after the bones. Because of the three places that you get calcium from, the bones, where else? The kidneys hang on to it, and vitamin D, you have massive bone destruction with hyperparathyroidism. Because it can have extra PTH and it goes after the bones and gets that calcium, so it just ravages your bones. So what dangers are for your patient? Osteoporosis, broken bones, fractures, all kinds of things. They're at a really high risk. They have muscle weakness and fatigue is no fun either, and they have those decreased deep tendon reflexes, but you're really worried about what it's going to do to their bone. Weakness and fatigue can put you at risk for falls too, but you really don't want that ripping through your bones. Okay, everybody remember why it goes at your bones? So you know when you see somebody who has an elevated PTH, you know why it's so hard on their bones. So what do we give them? Fosamax, estrogen, and oral phosphate. Now why would I give oral phosphate? Yeah, right, because I have extra calcium, and so when I have extra calcium, I'm going to be low on my phosphate. Perfect. All right, now I want you to go back to your chart. You get to fill in your very last blank that you have there. So if I have too much parathyroid, I have hyperparathyroidism, and I have elevated calcium. All right, now I think that's rounds to celebrate. Look at all that you've accomplished. Look how many endocrine disorders you've looked at. You've got how many on there? Count them up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. If you have done both sections with us today, then you've covered 10 of the most prominent endocrine disorders. You can at least clap for yourself, get a little excited, do something. That's very exciting. Yes. Hey, who cares if it's cheesy? You don't get enough encouragement in nursing school, do you? So it's good to get some when you come here. Excellent. Now, what you need to do to make that your own is just keep reviewing that tonight and take a look at it, because those are now yours. Because what are we doing here? Changing the way you study. That's what we're looking at. So last one up, you've got one more stick man. You looked at the symptoms for hypoparathyroid and hyperparathyroid. I think this is the most challenging one, so see what you can come up with. Ready? Go. We're going to give you about a minute to do it. Okay, good job. You should be finishing up hypo and hyperparathyroidism. Now we're going to go on and just give you a couple more, just going to touch on some of the other glands. First we're going to look at the pineal gland, pineal, however you'd like to say it, but it's located also in the middle of the brain. What other glands have we talked about that are in the middle of the brain? Hypothalamus and the wee little one, that's right, the pituitary. This one's in the middle of the brain and it secretes melatonin. We're not really good at knowing exactly how this works, but it's definitely attached to your sleep, when you sleep, when you awake, and so that if you start messing around with your melatonin, you've got some other issues going on. We're not going to really look at hyperpineal or hypopineal. We're just going to touch on the gland. So you remember that this is another key player in the endocrine system. Now on to the gonads. Yeah, that's kind of hard to say in a group of people, isn't it? But these are the ones that the main source of the sex hormones. For the males, it's the testes. For the female, it's the ovaries. The males are the ones that secrete the androgens, and this is the difference between the anabolic steroids. This is what's different than the corticosteroids that we talked about. The anabolic steroids that the bodybuilders use, those are where you get more like the androgens. This is what gives you the sex characteristics, and the female ovaries are the estrogen, the progesterone. They give the female secondary sex characteristics and regulate their menstrual cycles in pregnancy. All of which you had in elementary school when you separated the boys from the girls and you all got to watch your movies, right? And again, you learned about wings and strings, at least the girls did. Okay, well, let's move on to the pancreas. We're going to dig a little deeper into the pancreas because it's got a lot going on for us. Now, remember, it's an endocrine and an exocrine organ. So what does that mean? See if you can think back and tell your partner what's the difference between an endocrine organ and an exocrine. Remember, endocrine secretes directly into the bloodstream. Exocrine goes just somewhere. The pancreas secretes pancreatic juices into that biliary system, and it also secretes the insulin directly into the bloodstream. That's why it gets to be in both places. It's insulin and glucagon, so we're going to talk about insulin primarily. So it regulates the level of blood sugar in our bodies or in our blood. When we have issues with our pancreas, you end up with either type 1 or type 2 diabetes. We're going to talk about that a little bit more as we're going to move on to our section now.